finding that most of these facilities are understaffed. So since they are understaffed, there are some services that are compromised. They may not have time to do that comprehensive service delivery, because you find a facility, most of the facilities are below 50% staffing across Mbale City. So that means that when clients are many, some of them end up not being seen in a proper way, and they end up not getting all the services they want. And also had an issue of stigma and discrimination, especially among the adolescent girls, the young people. We also have the key populations that we serve. Those are people who use drugs. We have our sex workers. So when they go to facilities, they reported cases of discrimination and stigma in terms of giving them services. So we also had an issue of stock out of medicines and essential drugs, especially in HIV. We had issues around PrEP, whereby most facilities were giving to pregnant mothers and discordant couples. So when it came to our KPs who are most at risk, sometimes they would not get those drugs. And then we also had stock out of condoms and other healthy consumables at facility. So that one was also a serious barrier in terms of HIV prevention. We also had an issue of long distances. The data indicated that we had some clients who would move long distance to access some of these services simply because of gaps in some of the facilities that are neighboring them. These gaps usually came because of late coming health workers. A client is nearing a facility, but because the health workers of that facility come late, so they have to move around and look for a facility that is open so that they can get a service. So basically those are some of the gaps that we identified. There are so many, but I will not dwell on gaps, because as you heard my fellow EDs, they have told us in their findings as well, you know, CLM is evidence-based. So in their findings, we have registered so many achievements. After the 3 semesters, we have observed out of our feedback meetings and the data that has collected, especially in semester 3, we've had the reports from our community. Some of the facilities, as I mentioned, some of them, the health workers are coming. And that one, we really appreciate CLM for the intervention and the efforts of our stakeholders. They have also worked on issues of stockouts. Like in Mbale City, we have a redistribution approach, whereby if a facility doesn't have drugs or supplies, they try to outsource from another facility. They even have a center where they collect those drugs. So if somebody has run out of a drug, they will call, and then if it's there, they go and pick. So we commend. Yeah, it's Mbale City is using Busamaga Center.
I'm adding you 1 minute.
Yes.
To complete your contribution.
So we have some achievements, like the redistribution of drugs to address issues of stock out. We also had issues of emergency lighting in one of the facilities addressed. We have infrastructures that have been worked on. In the previous semesters, we had health workers going late because the road is bad. You know, Mbale is a rainy place, and some places are hard to reach. So if it has rained, a health worker will go late and tell you, I wouldn't cross. So we had those issues, but they were worked on. So going forward, as Mbale City and the Women with a Mission, we recommend that we should strengthen these dialogues at community level, because out of these dialogues and then the engagements with the community, we've been able to identify some of these gaps, and as my colleague said, we have been able to co-create solutions and then better our health system. We also encourage that we train our staff, especially the health workers at facilities. We have partners here, maybe they can support in terms of training them in client-centered care, so that we can reduce issues of stigma, discrimination, and then limited confidentiality. Thank you so much.
Let me give it back to you before you hand over the microphone. I hope you are aware that when the stop worker order came, one of the areas it affected was chronic care. And that one has led the ministry to guide that let services be what? Integrated. I want you to paint a picture, because you've talked of stigma and discrimination. Do you think this integration of services could have also led to the contribution of increasing stigma and discrimination? I want you to paint a picture.
Not necessarily, but partly. Because when you move to some facilities, we had facilities that had peer leaders, we had facilities that had health workers that are specifically trained to serve adolescent girls and young women, KPs. So when the stop worker order came and the integration came in, some of those health workers are no longer there. So that one also contributed to the stigma. Then we had health workers who were not trained, as I said. So they don't understand. I went to some facility where we were giving feedback to community. One of adolescent girls who was pregnant refused to go for antenatal because the previous visit was harassed by a health worker who asked her questions that she didn't understand. So she was requesting a VHT to go with her, or else she will not go back to that facility. So one of the achievements that we got out of our advocacy and then the feedback that we gave, some facilities have created those specific days for like clinics for adolescent girls and some special interest groups. So we recommend that maybe the same approach can be replicated in other facilities amidst integration, because we know integration is here to stay.
Let's borrow more seconds. Still you did share with us that there are clients who are moving long distances. Yeah. And the reason is late coming by health workers within their catchment area. So they opt to travel an extra mile for them to get better what? Better services. Sometimes they say local problems need local what? Solutions. Have we tried to bring the two facilities together such that the one that's not doing well can learn from the one that is doing well? I am not asking you directly, but I'm just putting it to the house that probably going forward, it could be one of the things we can what? We can adopt. What are the other people doing best that these ones are not doing? And how can we help them catch up? These are the same health workers. They are paid by the same government. Okay. Even the training they receive the same. So what could be their point of departure that the other ones are persistently coming late and these ones? Because there are many questions around that area.
Yeah, there are so many interventions that have been put in place to address that. But on our side, maybe to summarize, in the first place when we are giving feedback, just as you had the previous speaker, we always bring all stakeholders on board. We have been able to bring in the HUMIC that has helped us address issues at community. And also when we are doing facility feedback, they also come in, so they see some of these issues. We move with our feedback to the stakeholders, the decision makers at the city who pay health workers. So in most cases when we are giving our feedback, all the in charges of these facilities are there. They are watching. We share our achievements from the different facilities. So we hope that much as we've not yet arranged the issue of exchange learning, but such information help these other facilities to also better their services. Yeah. Thank you.
Thank you very much for fitting into the subject matter very well. And I think your ED must be happy you have ably represented him or her. And a round of applause from the house to this lady. She has fitted in very well. We are moving to my own TDN. Yes. You are the engine behind CLM. You are the one who gives us the push. You have heard what other colleagues have said. Yeah. So many things. And now here, we are still within the community. And we want you to share with us what are communities saying about the way services are delivered. How are issues such as staff attitude? Stigma again comes up. Confidentiality, respectful care. how are these issues affecting services? But bear in mind that Tororo is cosmopolitan. Bear in mind, Tororo is what? Cosmopolitan. Don't be shocked that all the languages, if you asked each and every member here to speak in their own language, you all find them in Tororo. Thank you.
Good afternoon, everybody. Helen Akwara is my name, and today I stand in the capacity of my executive director, who is out on official duties. I am a project officer, and I've been in position to interact with CLM a number of times. The question takes us to acceptability of health services. And yeah, before I answer the questions, maybe let's talk about what acceptability is. Acceptability means, it refers to whether healthcare services are respectful, culturally appropriate, non-discriminatory, and responsive to the needs and expectations of patients. You realize that sometimes, even when services are available and accessible, people may avoid them or delay seeking care if they do not find them acceptable. Let's now go directly to what the question is. What barriers are communities still facing in accessing health services? First of all, there is stigma and discrimination, whereby there is fear of being judged, which discourages many people from seeking care. Let's take an example. If government has previously, before the stop work order, we had different departments, the chronic care issue, and these people living with HIV were in position to get their drugs or medication from elsewhere. But when integration came in, we see that they're supposed to pick drugs from the same place. So somewhat it discourages them, like, maybe I do not want my status exposed or somebody gets to know it, and then at the end of the day I have to pick my drugs from the same place with the other community members. In one way or the other, it discourages me from going back to the facility to pick my drugs next time. Talking about the negative attitudes of health workers. Some patients reported being treated rudely, shouted at, or spoken to disrespectfully. And in such situations, if I come to the health facility as me, and I have come already with my problems, and I have come to the health facility, and then the first thing I see before I even eat, a midwife has been working day and night. Like, you're working during the day, and in the night you have to work. You get it? So at the end of the day, if a patient or a mother comes to deliver in the night, somewhat you will tend to be rude. The other. But the community does not understand that. Yeah. Another thing is there is lack of privacy and confidentiality. Once there is lack of privacy and confidentiality, we have inadequate consultation rooms in our facilities, the OPD is crowded. Somehow, you're compromising privacy. And you know, many facilities are operating with infrastructure that no longer reflects the populations they serve. They are serving bigger numbers, but the space in the facility is not adequate for all of them. When I went to Panyangas Health Center, I found mothers sleeping on the floor because the space that is there is very small, the seats are already full, and the only option they had was to put their lassos down and sleep there. So in one way or the other, somebody is discouraged. I'd rather maybe go to a TBA at the end of the day, because even there is no space for us. Like the moderator said, Tororo has a number of tribes, and if we all mentioned our tribes, trust me, we will find them in Tororo. And therefore that brings us to an issue of language barrier. Some of the health workers do not understand all the languages that these patients speak. Somewhat, they will try their best. They know basic words, and more frustration in Tororo than.
Thank you. That is Tidian for you. One thing I pick out from what she has shared is that the issue of burnout is real and it's affecting services. Members will be interrogating into what you have been discussing. That's at a later time. Let's go to our last panelist of the day. You're not the least, but you're the last. Or you have come at the end. This is Bukodi, and you're from Bukwo. We are still handling CLM issues. Although many services are offered free of charge, what finance barriers are communities still experiencing in your own experience? And how are these affecting continuity of care?
Okay. My name is Kipieko Laban. I'm representing the ED. I'm supporting M&E in Bukodi. We are talking about, I think that question is directing us to affordability of the services and the facilities. And those services are free of charge in all our government facilities. We still have some costs that come along the way. So some of the costs we found from the communities that they always give us. We have costs from the transport sector. Since from the community I come from, I can elaborate that on from the perspective of our area. In Bukwo, the place is very hilly, mountainous. So when you look at the facilities like a facility in Alalam Health Center, Siri, the facility is far away from most of the communities. So reaching to some of those, most of the communities reaching to those places, they face challenges when it comes to transport. See, where you're supposed to put in maybe a transport cost of 2,000, at the end of the day you may end up using costs of more than 5,000, since the roads that side are poor and the terrain of the area. So those are some of the things in Bukwo. Then we also have issues on some clients struggle to afford adequate food. That is, at the end of the day, they start fearing taking their medication, mostly some of the members, people living with HIV. Then we also have children, older persons, and people living with disabilities often require maybe a caregiver. So at the end of the day, even if the facility is nearer, most of these caregivers may want, since they want to rush and to take care of the person, they may not be available at the time and they need transport to go that side. Then we also have follow-ups. It also comes with costs, since most of the clients maybe can be through phone calls by the health workers and the service user. So communication sometimes fails because the service users cannot afford some of these gadgets. So at the end of the day, it's costing them. Then we also have costs in terms of missed medicines. Most facilities in our area report stockouts. And this comes, like in most respondents in Bukwo, report frequent stockouts in medicine. That was during the 3 semesters. And this causes treatment interruptions. We also have some facilities that may be needed to be coded for art and they are not coded. So some of these clients may travel a very long distance to the next facility to receive what? The art services. So how are these services affecting? These barriers affect the community in the following ways. That one, there is missed clinic appointments and delayed medication refills. Then there's poor adherence to treatment due to transport and food challenges. We also have interrupted treatment, increasing the risk of poor health outcomes. Reduced participation in community support groups and follow-up activities. Increased loss of follow-up among the vulnerable populations. So those are how it affects the community. So when it comes to our district leadership, that I think that most of them are around, We also gave them some recommendations, like in some facilities where the poor road, there's a serious poor road network, they should put in first priority on those roads such that people access services without incurring a lot of costs. Then we also pledge that those facilities that are not yet coded for art, they can also be coded so that people access the services nearer to their community. Thank you.
Okay, round of applause, ladies and gentlemen. We are almost coming to the tail end. Thank you, gentleman from Bukwo. He has articulated his issues, and it's now time that we come to appreciate what all the 6 panelists have been able to share with us about CLM. I think it has been exhaustive, educative, and there are some things to learn from them. I personally, what I have learned here is that the power of delegation is real. So if you're here and you don't know how to delegate, learn from here today. Every delegate here has delivered 100%, which is something very good for us to learn from. So your EDs, wherever they are, they should be happy. And Udha, I think you should be able to share this as a lesson well learned. So it is now time that I turn to the audience, and I want us to appreciate the discussion that we have been able to have. You've all listened to the 6, I think there's also gender balance. Wow, this is powerful. Let's first clap for that. Gender balance, 50%. I think, Udha, you need to return again. Don't go for real. You need to return. You know how to do things. Yes. We are not doing well via time because we started late, but I'm only going to give chance to 1 lady and 1 gentleman. Am I being fair enough? Okay. 2 gentlemen and 2 ladies. Thank you. Dr. George.
Thank you, and allow me to stand up.
Please.
You may also give me some few minutes, eh?
I have already done that.
Okay. First of all, to appreciate all these people. I think they have understood where we are coming from in this space of community-led monitoring. And also to say that I am grateful that we brought CCM members here and also TASO members here, so that as we try to understand how CCM can deliver to us what we want in as far as aspirations of the community is concerned in terms of health, we needed also to have, in attendance or as participants, our political leadership of the districts, cultural leadership of the district, and also some opinion leaders of the districts here. I told you services are gradual and continually moving out of facilities into the community. And my lady there, for lack of a better word, I think, if I use a very inappropriate word, forgive me, but you did wonderfully, very well. When you mention that lack of public trust or low community trust in our healthcare services, I woke up. I don't know whether I had been sleeping. I woke up. And why I woke up is that in health sector, we many times bury our heads in the sand and pretend that we are actually meeting the aspirations of the public, when actually not. True, many of our community members still go to TBS, go to other people who are not within the facility which we are talking about. And I know for sure and for a fact You are saying you have done your 3 semesters, you have done your first semester, you didn't have a retake. Whichever semesters you are talking about, I don't know. But all your semesters were more or less from government facilities, isn't it? If any, maybe very few or limited private facilities. But remember that all these people we are saying have low community trust in our facilities or in our services, okay, end up in the hands of the TBAs. Now, if you said they are TBAs, I still agree, even when we said there should be no TBAs. In this region, I know mothers who deliver in facilities are more or less about 60% of all those ones who maybe get pregnant. 60% deliver in facilities. Where do they 30 deliver from? Now, that's about pregnancy, which is not stigmatized. Okay? If you want to stigmatize pregnancy, you better get out from here, because the diseases for which CCM is here are diseases which carry stigma to 100%. Maybe malaria is not stigmatized, but HIV, TB, all are diseases with very high stigma. And yet here we are talking about integration, that let's integrate into HIV so that we can leverage on the resources of HIV. Let's integrate into TB so that we can leverage. Okay? Now, the more we integrate, we are even carrying away diseases which initially were not diseases of stigma into the space of stigma. That means to study, Minister Well is saying, let's do also medical tourism. We follow from behind from Minister of Health. We are beginning to talk about medical tourism when actually those of Dr. Mulungu are already in medical tourism. There is religious tourism. How did I follow? I was in a plane, I was coming from South Africa. Now there are these people who said, there's this church there